Welcome to The Explainer. Today, we're going to break down one of the trickiest stations out there, the pediatric chest exam. It can seem super intimidating, I know, but trust me, with the right system, you can absolutely nail it.
So, let's get right to it. What's the one thing on every student's mind when they walk into that chest station? What really separates a pass from a fail? Well, it's probably not what you think. It's not about rattling off every rare disease in the textbook. It's much, much simpler.
It all comes down to having a system, a foolproof, reliable sequence that you can fall back on, especially when the pressure is on. It's a safety net that makes sure you don't miss the big, critical stuff, no matter how nervous you get.
And in this explainer, we're going to give you that exact system. We'll break it down into 5 easy parts. We'll start with the absolute non-negotiables. Then we'll cover a hands-off scan, a head-to-toe exam, then dive deep into the chest itself, and finally, show you how to put all those clues together.
Okay, let's dive right in. Part 1, the pass/fail stuff. These are the absolute, cannot miss, must-find observations for this station.
Seriously, think of these as giant, flashing red lights for the examiner. Missing things like the respiratory rate, cyanosis, or scars, well, that can be the difference between a pass and a fail, simply because they point to some pretty significant problems. We're going to keep coming back to these, you'll see.
All right, now for the first step in your system. This happens the second you walk into the room, before you've even said hello or touched the patient. It's what we call the 4D scan.
And we've got a super simple mnemonic to help you remember it. Dysmorphic, distress, dimension, and device. This is your rapid, hands-off assessment that helps you gather a ton of info right from the doorway.
So let's break it down. Dysmorphic. Are there any syndromic features? Distress. Is the child clearly struggling to breathe, maybe breathing really fast? Dimension. Do they look small for their age? That could hint at a chronic illness like cystic fibrosis. And finally, device. This one is huge. Scan the room. Is there an inhaler, an oxygen tank, a sputum pot? Missing something like that is such a classic, easy mistake to make, so always look.
Okay, so you've done your 4D scan from the door. Now, it's time to move on to a focused but still general head-to-toe exam. You'd be amazed how many clues for a respiratory problem are hiding far away from the lungs. And before you dive right into the chest, you're going to start with the hands. Just remember this little mental checklist. CBT. We've already said C, cyanosis, and clubbing are pass-fail items. And the T is there to remind you to check for tremors. And this is where being a good detective really pays off. A little tremor in the hands could be a side effect from their Ventolin inhaler. See some oral thrush in the mouth? That points right to steroid inhaler use. A shunt on the head? That's a massive clue for a condition like primary ciliary dyskinesia. See? They're all puzzle pieces.
All right, it's time for the main event, the local chest examination. We're going to break this down into the classic 4 components: inspection, palpation, percussion, and auscultation, and give you a system for each one.
First up, inspection. For this, just use the mnemonic RRDDS. Now remember what we said earlier? 2 of these are pass-fail items. You absolutely have to count the respiratory rate, and you have to look for scars. And here's a pro tip. Always ask the patient to lift their arms so you can check their sides for a lateral thoracotomy scar. It's so easy to miss.
So, I'm going to say it again because it's that important. Always count the respiratory rate and always have the patient lift their arms to check for those hidden lateral thoracotomy scars. These are non-negotiable.
Okay, next you're going to put your hands on the chest. For palpation, just follow the sequence ATE. First, find the apex beat. Is it in the right place? Then, you'll assess tactile vocal fremitus, and finally, check chest expansion.
Now, tactile vocal fremitus, or TVF, can be kind of confusing, right? You're feeling for vibrations as the patient talks, but what does it mean if they're stronger or weaker? It can feel a bit abstract.
Well, don't worry. There's a fantastic analogy that makes it super clear. Just think of the lung as a balloon. If that balloon is filled with just one thing, like just air in asthma or just fluid in an effusion, the vibration is decreased. But if it's filled with air plus fluid, like in consolidation, the vibration is actually increased. Just remember, plus equals increased. Simple as that. Next up is percussion. Now, the key here is to be methodical. Follow this exact pattern, and this is crucial. At every single spot, you have to compare the left side to the right side. That comparison is what tells you if something's wrong. And the sound you hear? It tells a story. If you hear a dull thud, that suggests something solid or fluid-filled underneath. like a consolidation. But if you hear a big, booming, hyper-resonant sound, that's a classic sign of trapped air, like you'd get in asthma or with a pneumothorax. All right, you've done it. You've inspected, palpated, percussed, and auscultated. You've gathered all your clues. Now for the final and most important step, putting all those pieces of the puzzle together.
See, your findings aren't random. They point you towards a diagnosis. If you found clubbing and that hidden lobectomy scar, you should be thinking about chronic suppurative lung disease. See a child who's small for their age with some Creon vitamins on the nightstand? Cystic fibrosis has to be at the top of your list. And if that apex beat was on the right side, you have to consider Carter-Jenner syndrome.
And here's a pro move to wrap things up. You always want to end with this golden phrase. I'd like to complete my examination by, and then mention things like checking the liver span or performing an ENT exam. It shows the examiner you're thinking about the bigger clinical picture, not just the chest in isolation.
Let's finish with a really powerful reminder from the source material. It's a quote from someone who learned this lesson the hard way. They didn't miss some complex physical sign. They missed the sputum pot next to the bed. It just goes to show you, the smallest observation can be the most important one.
And really, that's your big takeaway. A good, systematic approach means seeing not just the patient, but the whole picture, the patient, the room, everything. It's about being a detective. So master the system, and you'll master the station.